Thank you. I'm mainly here because of my dear friend Habib, who actually invited us to come and share our experience and more importantly, share the knowledge and mutually. And I'd like to thank the organizers for a wonderful meeting as well. Without wasting time, I'll just move on to the topic as well. I've been given a very basic talk about incisions, sutures, needles, wounds, and that's what makes us surgeons. It's important that we understand the principles and concepts so that we do things right and avoid disasters as well. Some disclaimers, I do serve on the faculty on various committees as well. We do have a couple of books as well, but now commercial interest, any of the implants and devices, the publishers made the fractures book a limited size available at the front desk itself. So when you talk about incisions as such, a good incision one where it's very simple to follow and create. It's easy to close, sometimes even non-closure of wounds, just applying a glue and opposing the ends like we do in endoscopic DCR is a classic example of a very good incision, where you don't even need a suture to oppose the wound itself. It should directly or indirectly give you access to the area of interest. And finally, end of the day, the worst thing that patients always fear when you make an incision is, am I going to have a scar? So it should be aesthetically acceptable. So I'm going to touch on some pearls which we use for incision making and eyelid lacrimal orbital surgeries. This will be slightly non-textbook as well. So look at eyelid incisions. Yes, we make incisions in the skin. The first thing the patients ask about, where is my cut going to be? So that's where you all have an advantage because almost all of your patients have a nice upper lid crease for upper lid orbitotomies, eyelid surgeries as well. Whereas we Asians or East Asians, the Chinese faces, half of them don't even have an eyelid crease. So that becomes a challenge itself. In the past, the standard approach to the lower eyelid was always a subciliary approach, just again on the skin. But people are giving an infratarsal or even a lower lid crease incision, we completely have moved away from it. And when you talk about eyelid, not all incisions are on the skin itself, they're on the conjunctival, the posterior side as well. So when you learn your anatomy, you don't necessarily have to learn it from skin to deep, but you should probably know your anatomy from deep to superficial so that you know what structures you're going to be dealing with, because the posterior approach is what we use for a variety of ptosis surgeries and eyelid retraction surgeries. So these are the various incisions which is there in your natural creases. In the past, we used to create a nice dorsal nasal incision for external DCRs. We completely moved away from it. We put them in these lines called the relaxed skin tension lines. And when you want even the same incisions for the orbit, with a little canthotomy, you can access the different parts of the orbit, the floor, medial wall, and the lateral wall. So coming to lacrimal surgery, what are the incisions that we make? Yes, we still do a few external DCRs, but the vast majority of lacrimal drainage surgeries are now endoscopic DCRs, at least in our practice. But the regular resident and the ophthalmologist and the junior oculoplastic surgeon has to become familiar with an external DCR. And once again, we are looking for natural existing lines on the face, and typically in the tear trough deformity where you have the relaxed skin tension lines. There has been a subciliary incision which has been described. It's a little different, difficult to access to the lacrimal sac area. L.V. Prasad published a paper on it as well. And when you're doing big lacrimal surgeries for malignancies, then we do a Weber-Ferguson incision. I'll talk about it in approach to my orbit itself. But when you make an external incision in medial canthus, do not cross the medial canthus. You really don't have to detach a medial canthal tendon for doing a good DCR. Only the complex canalicula DCR that you really have to do it. And if we do a nasal mucosal incision, these are example of skin incisions. So my favorite is what you see on the top left over here and moved away from the dorsal nasal incision. So when you go to the mucosal incisions, in the past, we were creating an incision, chopping off your mucosa. Now, the more delicate you handle these incisions, the better the wound healing. And preserving the nasal mucosa and preserving the lacrimal mucosa and opposing to each other, sometimes with glue, sometimes with nothing, and there are surgeons who even use sutures, actually aid healing by primary intention, which we'll talk about later on, rather than secondary intention, which is the way it was going to be there as well. And this is ideally created with a cold steel knife or a radio frequency device. So coming to orbital surgery incisions, the same incisions that you learned for your eyelid is basically the same incisions used for your orbit with slight moderate variations as well. You use the traditional upper lid crease approaches with or without a lateral canthotomy. You can do a little swinging eyelid approach when you combine it to the posterior conjunctival incision itself. We kind of moved away from incisions in the subbrow, which goes to the lateral canthotomy, because when you're doing a large osteotomy, it used to give better approaches, but nowadays we're able to create good approaches itself. And if you go to the medial orbit, that's where it's the most vascular, most crowded compartment of the orbit. we have to use various creative ways of doing it. The retrocurruncular approach is a favorite incision which gives you direct access to the medial wall of the orbit, be it for orbital fractures or decompressions itself. But you have a nice large tumor in the supromedial compartment. The vertical lid split, which is nothing but both a conjunctival and a cutaneous incision, gives you really an open door approach to the supromedial orbit. You can do all the biggest surgeries that you want and put it back together like a simple lid laceration so that you will not have any scary scars. Coming to sutures. The purpose of the sutures to oppose wounds, and if you create a good wound along a relaxed skin tension line, more often than not, the subcutaneous sutures do most of the work itself. And the principle of a suture is to stay as long as it needs to be. They can be classified into permanent and bioresorbable sutures, and by default, the greatest innovation both in pediatric and oculoplastic and facial plastic surgery is the creation of bioresorbable sutures, the Vicryl sutures. The silk is now, although a gold standard of sutures, mainly used for traction, and that's about it. And skin is usually we end up using more Prolene rather than any of the silk or any of these sutures itself. Again, these are various classifications. More often than not, deep inside use bioresorbable sutures unless you're securing certain implants and devices. That's when we use permanent sutures as well. So general principles for sutures is generally for skin, non-absorbable sutures because you want the patients to come back, remove it at a 5 to 7 day period. Subcutaneous sutures by default is Vicryl. Levator is controversial. I tend to use absorbable sutures. And mucosa, you hardly ever sutures, but if you do, we end up using Vicryl sutures itself. Question for the postgraduates, is nylon permanent suture or not? You think about it and we'll answer it in the discussion session itself. Coming to needles, you can have curved needles. We don't use straight needles itself. You have semi-curved needles and even the ski needles, which are used in various compartments. And these are the various sizes of needles that we use. Generally, for oculoplastic purposes, it varies from 4 to 6 sutures, occasionally the 7 sutures as well, and you can see the various applications that you see as well. But for the general ophthalmologist who's familiar with using even 10 and 11 sutures, you kind of know it is for corneoscleral closure, whether it's a permanent or absorbable sutures itself. It is important, not all needles are the same. The variety of round body to cutting to reverse cutting, we hardly ever use round bodied sutures usually. Cutting and spatulated needles are what we use. Spatulated needles are where you want to preserve the same plane, say it's a tarsus or sclera and so on and so forth. But for skin, generally we use a cutting, or if you don't want the needle to cut through thin skin, you use a reverse cutting needle as well. Finally, a couple of points about wound healing. Healing by primary intention, secondary intention, and there's something called a tertiary intention as well. Primary intention is the way you want to do it because that's where wound healing occurs the best possible way. Perfect apposition, there's blood accumulation with a minimal amount of granulation tissue. Epithelial overgrowth happens over 24 to 72 hours. So practically the wound is water dry by 24 to 72 hours, and most of the healing is occurring within with minimum amount of contraction. Versus if you do not close your wound well, or if you have an infected wound where you're doing a lot of debridement, that's when you have a raw area there, then you have a granuloma that forms, which heals by secondary intention with infection, secondary contracture, leads to depressed scars and ugly scars. So as a surgeon, you want any wound to heal by primary intention, not secondary intention, but every once in a while we do what is called a delayed primary closure, say if an evisceration for endophthalmitis or panophthalmitis. If you have a road traffic incident where the skin is all macerated and crushed, you just debride the wound and slap a simple dressing on top of it, letting it close, or when the infection is gone, then going back and closing itself. So in summary, I touched a little bit very briefly on the various incisions, sutures, needles, and various applications. Most of this is decided preoperatively, but every once in a while you want to be creative on the table so that it can modify techniques itself. You have to execute good intraoperative technique to follow through on the preoperative treatment planning, aim for primary treatment closure so that you get excellent postoperative recovery. Thank you very much.